Welcome, everybody. I'm so happy that you can join us this morning with our webinar on understanding palliative care. And this is an event in our Conversations with Leaders series. Before I begin the conversation, I'd like to acknowledge that we are located on the unceded and unsurrendered territory of the Anishinaabe Algonquin Nation. We work here and pay our respects to Indigenous elders past, present, and emerging. Now, I'd like to tell you just a little bit about Compassionate Ottawa, the organization that hosts these webinars, and I am a member of the board of directors of Compassionate Ottawa. Then I'll introduce myself and I'll introduce Dr. James Downar, our guest speaker. So, Compassionate Ottawa is a community based charitable organization that helps people develop knowledge, confidence, and connections that they need to navigate serious illness, to navigate caregiving, to navigate grief and loss, and also to engage in advanced care planning. We believe at Compassionate Ottawa that care is everybody's responsibility, and strong, connected communities play an essential role in supporting people through life's most challenging transitions. We engage in education, community engagement, and volunteer-led programs. And by doing that, Compassionate Ottawa creates opportunities for people to learn, to connect, and to have meaningful conversations about topics that affect us all. So I'll start by just telling you who I am briefly. My name is Louise Hanvey. I'm a volunteer with Compassionate Ottawa, and in my volunteer role, I lead the advanced care planning and conversations program that we run. I'm a retired registered nurse, and I've worked on many national palliative care initiatives. Most recently, I was the manager of the Advanced Care Planning in Canada project with the Canadian Hospice Palliative Care. And we initiated the Speak Up, Start the Conversation about End of Life Care initiative. And that's what brought my interest to this topic. I've done other areas of nursing in the community, in the hospital, and public health. And now it's my pleasure to introduce our guest, Dr. James Downar. Welcome, James. We're glad you're here with us this morning. Whenever we do workshops in the community, no matter what the topic is, if it's about advanced care planning, if it's about grief and bereavement, if it's about just compassionate communities in general, people always have a lot of questions about palliative care. And so we're thrilled that you're here this morning to share your experience and your expertise with us. Dr. Downar is a critical care and palliative care physician in Ottawa, and he has a master's degree in bioethics. He's professor and head of the Division of Palliative Care at the University of Ottawa, and he holds a clinical research chair in palliative and end-of-life care. He's an adjunct professor at the Australian Centre for Health Law Research at Queensland University of Technology and past president of the Canadian Critical Care Society and co-chair of the Pan-Canadian Palliative Care Research Collaborative. He has authored hundreds of peer-reviewed publications, has been the principal investigator on more than 30 peer-reviewed grants, and in 2025, he received the King Charles III Coronation Medal for his contributions to palliative care in Canada. So you can see that we are really honored and lucky to have James join us this morning. So James, I've given everybody sort of your clinical and scientific CV, if you will, but I wonder if you could share with us on a more personal note what brought you to the work of palliative care, why you continue to do this work, just who you are.
Thank you very much for that introduction, and very good to be here today. And thank you for those of you in attendance. I think my start in palliative care was probably an interesting one. I remember when I applied to medical school, I remember there was a mentorship program that they had in medical school where, as you're about to enroll and, you fill out a form. In those days, it was all paper, if you remember what paper is. And you had to write down, sort of if you had any particular interests in certain areas of medicine, areas you were not involved in, not interested in, and any specific requests for a type of a mentor. And if I recall correctly, the only thing I wrote on that form was that I didn't want to do palliative care and don't put me with a psychiatrist. So sure enough, they put me with a psychiatrist, and here I am in palliative care. Life is sometimes not exactly a straight line to get to your objectives. I think in my, I came into medicine like many people, you sort of want to save lives and fight crime. You want your Superman moments and you want to stamp out disease wherever you find it. The reality of medicine is quite different. You certainly do get your opportunities, but they're not as common. Most of what you do in medicine is you manage illness and try to keep people in best state of health that you can. Certainly, the type of medicine that I do in internal medicine, and you're as often as not, the focus has been shifting much more towards quality of life and rather more than quantity of life over the years. And this shift is, I think, much more apparent to people now than it used to be. But even 20, 25, 30 years ago, there really was much more of a questioning of whether all of the things that we were doing to prolong life was necessarily patient-centered, and were we focused on the right questions for patients based on what their interests were. And I remember some very sort of critical moments in my training where you would have a really important family meeting where at the end of that family meeting, everybody was in a much better state of understanding and acceptance of the realities of an illness. And you just see the relief on the face of the patient. I think probably the greatest moment of gratitude that a patient ever showed me was when I fixed their constipation. It was things like this that just sort of, after you have, 2, 3, 4, 5 of these experiences, you start to realize that, maybe there's something to this whole palliative care thing. And, so I went and did an elective to experience it and became, rapidly enamored with the field and very interested in pursuing it and finding ways that I could combine it with what had become my other interest, which is intensive care. Many people find those two fields to be potentially they're diametric opposites. How could you possibly do both of those things? I didn't think that they were opposites. I found that a lot of what we did in ICU was actually heavily focused on understanding realities of disease, understanding the limitations of the treatments that we use, but also making sure that our care was focused on patient-centered goals rather than just keeping things going. It's very easy with machines to keep people going and keep the heart beating and oxygen going in and out of somebody. But how often does that lead to what the patient would value as an outcome? Where what is that really what they're after? And I think when you have more and more of these conversations with individuals, and it becomes apparent that very often the best you can do in the ICU is fine, but it's not actually putting this person closer to their goal. And that's something that they would not want to receive, understanding what their clinical situation was. And so I think I did a lot of my early work and early research work was around the integration of palliative care in the critical care environment, particularly. So I was involved in helping to draft guidelines and that sort of thing. There are others that came before me. I certainly wasn't the first. I was the first to get both training in Canada, along with a colleague of mine, Dr. Hartwick, here in Ottawa. But there were other forerunners, who had done excellent work in this area, like Dr. Randy Curtis and Dr. Gordon Rubenfeld. I'll just name those two individuals. But there were many others, Dr. Deborah Cook, who had done a lot of work on this out of Hamilton as well, and she's got the Order of Canada now. And, you have all sorts of really important, strong mentors and people that have really paved the way for somebody to do a much more formal integration of the two in an academic sense. Over the years, my interest in palliative care has not been limited to the ICU setting. I was really interested. I think the main area of overlap I was initially interested in was trying to develop communication training and help physicians, be more comfortable, skilled at leading meetings around this. It was clear that very often people are getting care that's not consistent with their wishes, and one of the main drivers of that is that people are just not having good interactions. Communication was poor. And I know that's an area, Louise, that you're very interested in from your past as well. So improving communication skills among healthcare providers and developing educational interventions became a big focus of the early part of my career. I did a fair amount of that work and did some publications around that. And that was really interesting to me. And I found that in general, people were very receptive to this. Like a lot of people were interested in improving these skills. And you saw it did have some effect, when you noticed that the learners were picking up the skills and displaying it at times. As time went on, though, I think it became apparent that education, even is even a very resource-intensive educational experience, like a simulator or hiring actors to pretend to be standardized family members that you would talk to and bolster your skills. That was not actually sufficient to really change practice. So it's necessary. It's good to build skills. But there's so much in the hidden curriculum of what goes on in medicine with people, everything, the world is on fire all the time. You're always rushing around to manage crises. And that there's things that are important, but less urgently in front of you, like the need to talk about goals of care with someone. Those sometimes get pushed to the side as they always do in crises. And so realizing that we needed more than just this kind of education. You needed ways to, structural, systematic ways in which you would try to bolster the system. So to make the system encourage and facilitate those interactions, right? Rather than having them pushed back and back and back. So how do we make conversations more routine with people? How do we focus our time and energy? Because, when people go to these sessions and they learn the skills and then they say, this was great, I thank you, I feel so much more comfortable now. But then you go up to the ward and you'll see very often people are still not engaging in the conversations because, and then, you get into a lot of human psychology, which I won't review here because I'm not necessarily an expert in it, but, things like nudge theory and Thaler's nudge theory, for those of you familiar, that most of what determines what we do and how we prioritize things can be affected by simple, environmental cues and nudges and reminders. And when cleverly done, they can be very effective. So I started to become more interested in how you generate and build a system that can be more encouraging and prompting of medical teams to deploy their skills and try to bolster and try to sort of work on that, not just telling them what to do, but helping remind them when to do it. And so we sort of used and adapted. Ontario is a big leader in the use of health services research data, big data, if you will, administrative data that tells you about patients going through the healthcare system. So we have incredible repositories of information about the care we're delivering. And very, very clever epidemiologists have used this data to develop models that are quite accurate at predicting the probability that somebody is going to, die or deteriorate in the coming year after a health event like an admission. And so, but through adapting one of these models, we were able to build it in. So these models were built on administrative data that piles up after somebody leaves the hospital. So you can, in retrospect, very accurately predict who was likely to have died and who was at greatest risk. But modifying it slightly, you can actually do it in real time. So when somebody comes into the emergency room, the computer, just with data that's already in the computer, can kind of calculate and figure out who's at highest risk. And using this, we were able to develop a model that would actually deliver prompts to the medical team. So not for everybody. You have to be careful. You start sending prompts about everybody, and they get ignored, right? Like people don't act on them. So you have to be strategic. You have to pick a small number of people that you're going to really push people to pay attention to. So how do you identify the highest risk group? Go prompt them to go talk to them and discuss, make sure that the goals of care are clarified, that any unmet palliative needs are identified so that you can develop a plan to manage and improve their outcomes. And then we've actually now done projects where we've rolled this out across a number of hospitals and start to get this sort of computerized system going. And we found that there have been fairly, substantial, and in some cases fairly dramatic improvements in care when you do that. And that's without even doing all the training and all the extra stuff. This is just building the infrastructure to tilt people. So it's, starting to use the infrastructure and the system, the way it's designed, starting to tilt the table, I guess, a bit in your favor, to sort of remind people, to nudge people, to sort of, to do the things that we've wanted them to do all along, and for which they are increasingly becoming skilled at doing. And that's been a very encouraging thing to see. So that flowing from the educational into the system level interventions to improve outcomes there. So that's a kind of, my a long answer to how I got into this and how I sort of swung through the system through the main axis of what I did.
So thank you for that. I mean, that really, I think, tells us about sort of one of the main goals, purposes of palliative care, which is to ensure that people get the care that they want, that's aligned with their wishes. And it sounds like all of that work that you've done was sort of moving the bar in that direction so that clinicians were more comfortable having the conversations. So can you tell us sort of what, in sort of holistically or in total, what palliative care is? So what are the, what's the focus of palliative care? What kinds of care do people expect in palliative care? When should they get it? Who provides it? I think there's a lot of myths around the palliative care words. Mm-hmm. And if you could just share with us, building on the key goal, which is that people get the care that they want, what are the aspects of palliative care that people should expect?
Yes. So, and again, it's a bit complex sometimes to explain, like we do a fairly extensive training in this to give a short answer, and I'll try to give a short, useful answer to people, who are genuinely concerned. Like I think that people a long time ago, and by a long time ago, I'll say even when I started training, I think there was a lot of fear of the term palliative care. I think that fear level has gone down dramatically. I think there's much more embracing of palliative care now, but important to understand what exactly we're talking about here. So palliative care is not a place. Palliative care is not the same thing as end-of-life care. Palliative care is a type of medicine, a field of medicine that is focused on quality of life primarily, and what that can look like. It often has sort of three main components, if I can point to it. So one of them is symptom management. The things that we do most commonly would be symptom management, where somebody with, for example, it could be a physical symptom like pain, or shortness of breath, or nausea. So we would be, using both medical medications, sort of pharmacological treatments, but also sometimes non-pharmacological treatments like interventions or other forms of therapy that would be addressing those physical symptoms and try to keep them as controlled as we can. Ideally, resolve them completely. Although, to be realistic, we often don't achieve complete elimination of a symptom. But we can generally get things, or often get things, under control, so that they're improved to the point that people find it manageable. So physical symptoms. You also have psychological symptoms that can be really important as well. So anxiety, depression, and what is increasingly the focus of much work, including some of my own work that I can talk about later, existential distress. So these are people who are really experiencing some psychological distress as a result of the situation that they find themselves in, both medically and perhaps socially. And so how do we address those needs? And again, we have certain types of medications and non-medication approaches that we can use to try to address that psychological distress and existential distress as well. So one key part then is that symptom management and meticulous attention to symptom management, and understanding that might require an initial attempt and then a new attempt, a second, a third. It's often the case that we don't get it right on the first go, and we need a couple of kicks at it. And then, but generally speaking, I would say in most cases, we are able to manage symptoms, certainly get them into the controllable range for most people, I think is a fair statement. Another big thing that we do is goals of care and care planning. So where we engage with people to make sure that they understand, first of all, what is their medical situation, what is the likely pathway that they're going down in terms of a prognosis, how long they have, or what is the possible range of prognoses that they might have. Sometimes that conversation involves a consideration of what they're getting, what treatments might be on the table, and to what degree each treatment might change that pathway. Does it change it significantly? Does it not change it significantly? And this could be an important discussion, not only of how long somebody might have, but what their future might look like in terms of symptoms and function as the disease progresses. This may also involve more direct care planning in terms of deciding, like, are we at the point of an admission and a deterioration? Are we going to start to establish some parameters around limits of care that they wouldn't want? So, a conversation I will commonly have with somebody, for example, would be to say, we're at a point where they're getting treated. We know the disease is not curable, but it could be manageable for a while. They've now got a complication that might be an infection or some other problem. And there's a reasonable chance that that infection is going to respond to medical therapies, and we're going to try those, and we're hoping for the best here. But understanding that nothing, things don't always go according to plan. Nothing is 100% successful. That if things were to get worse despite our best efforts, what are we doing in that context? And sometimes it's appropriate to sort of look at the situation and say, look, here you are. If you respond to this therapy, you're likely to recover. You're likely to be eligible for more therapy for your underlying disease, if it's cancer or whatever, and we keep going. If you don't respond, though, and if you get worse and worse to the point that you need organ support or life support, life-sustaining treatments, are you, the likelihood that you're going to be able to turn the corner at that point and recover to the point that you'll be able to live independently or get more treatment is starting to drop, and can drop quite a lot. Sometimes it's zero. So sometimes a reasonable plan would be to say, look, we're going to go and try our best with the medical therapies, and we're going to give those the best shot we can. And if they work, they work. But if they don't work, if you get sick enough to need life support, you're probably too sick to really benefit from it. So we're not going to cross that line. So we'll provide comfort care if the medical therapies are not. We'll sort of continue to manage you with more comfort care if the medical therapies are not sufficient. So that might be an example of a goals of care a treatment planning conversation that I might have with somebody when they come into a hospital. In other cases, it may be very clear that they have much more advanced disease and they aren't responding, and that they don't want any medical attempts at therapy, in which case we focus purely on comfort care in the anticipation that they're likely to pass in the near future, die in the near future. And in other cases, we may be involved very early on in care, where we're focusing on symptoms, etc. And if they get sick enough to go to the ICU, they go to the ICU, and we're not going to put any limits on their treatment, because we're still hopeful that that's the kind of thing that they could come back from. And our job in palliative care is to make sure that the symptoms are being managed and that we're supporting the person. And it's not that we're excluding the possibility of more aggressive treatments. So those conversations, I'm just trying to give you a bit of a sampler for the kinds of conversations that we get involved in when we're doing care planning with somebody. So we talked about symptom management, we talked about care planning. And then another big thing that we get involved in often is family supports and social supports for people. So we try to coordinate to make sure that caregivers have the information that they need, that they need to be involved in care planning as well, because there are many situations where caregivers need to speak on behalf of a patient when they can't speak on their own behalf. There may be situations where you need to activate community supports, personal support workers, community nurses to come and help, and sometimes even community visiting physicians will actually come to their place and manage their care there. And so, the support might be for their own distress as caregivers, making sure that they feel supported and that they have coping strategies for how to manage their role and the distress that comes with their role as being caregivers. Finally, Finally, the other thing, unfortunately, we have to provide sometimes for people is bereavement support. So when a caregiver or family member loses a loved one, we don't want the care to stop and the support to stop. And so there's been increasingly an attention paid and focus paid to how we start to fill that gap, that sort of bereavement support gap. How do we address complicated grief? Severe grief reactions, for example, or just simple practical supports for somebody who's really just having some social distress after the loss of a loved one. When you lose someone who's close to you, even a high functioning person, sometimes you just need a bit of help with things. So I would say in a broad sense, those are the three main sort of domains of what we do in palliative care. And it can get much more complicated and detailed than that, but on a high level. So from the examples I've given you, I hope everybody's gotten the impression that this is not simply end of life care for somebody in the final 2 days of life, which was classically how many people viewed palliative care. So sometimes people were afraid of palliative care for no other reason than the fact that we were just, we would show up just slightly before the priest, and that's obviously can be a scary thing to hear. And as you're confronting this, and in the old days, sometimes medical teams would not even feel comfortable talking about death and dying, and they would sort of send us in to do all that rough stuff, and we would get very little in the way of introduction. And the patients were kind of sideswiped by the whole thing and like, whoa, hang on, what's happening? And they'd be very resistant and upset that you're suddenly dropping this bomb on them. So again, that's very much changed. I want to be clear that I think people are much better equipped now to talk about limitations of treatment, death and as well as death and dying with their patients. So palliative care now comes in more as a welcomed guest rather more than the sort of the scapegoat for all the bad things that we don't love talking about. And I think that's palliative care, of course, can be provided at any phase of illness. So we get involved all the time in the care of people who are still getting care aimed at cure or certainly long-term remission of a cancer. We get involved in patients who are awaiting organ transplant. So we manage symptoms as they're on organ transplant waiting lists, for example. We get involved in the management of chronic illnesses that may have years, decades of life left, but have significant symptoms that need management, and we get involved in that. So those are all examples of that. I've been consulted to see patients that didn't even have a diagnosis. But they obviously had something bad. We just didn't know what it was, and they were having a lot of symptoms, and that's okay. I know, generally speaking, I can do my job without necessarily knowing specifically what's wrong with the person that's driving all the symptoms. Sometimes I can do a lot of the symptom management and contingency planning just based on the limited information that we do have. And so, we have a role to play potentially in many parts of life. The other thing is that palliative care is not necessarily a person. So the distinction between, are you seeing a palliative care specialist or a generalist provider who provides palliative care, for example, the vast majority of palliative care in any system cannot be provided by a subspecialist, the same way that, for example, not everybody who has high blood pressure is going to see a specialist in high blood pressure or cardiologist, right? You have your family doctor, is the general practitioners manage the lion's share of high blood pressure, high cholesterol, diabetes, for example, all sorts of conditions that are managed by generalist providers who have a sufficient level of expertise to manage it. And they will involve specialists for more complicated cases that challenge them. So with time, as we are part of our job as the palliative care community expands, and it is really expanding, we have dramatic growth in palliative care and the number of palliative care providers across this country over the past decade. But still, we're never going to be at the point where even the majority of palliative care is going to be provided by people who are specialists, specialist providers of palliative care. So we have to understand and appreciate that that's not ever going to be feasible, nor is it even desirable, because it's actually important that for all the referring providers or the specialists in other fields are competent in the basic management of palliative issues for the patients that they see. So so that's a big thing. So that's what palliative care is. I think you also asked me how it was accessible, but do you want to clarify?
Yeah,
before I do that?
I mean, I really appreciate you talking about the fact that a couple of things I heard really clearly. You don't walk, it's not end of life care, that it's really important that you're engaged early in whatever. Sometimes it was interesting when you said some people don't have a diagnosis, but they clearly need support. The other thing you talked about was sort of the breadth of people that provide palliative care. And my understanding, you said it's not a place, so it's many places and that it's many different kinds of providers and supporters. And would you agree with that? Like
Yes.
nurses, hospice volunteers, chaplains,
Yeah,
psychologists.
palliative care is a team sport. So it's definitely something where, we have, like, as a medical person, my principal area of expertise is going to be around some of the more medical interventions, particularly pharmacologic interventions, but also certain types of surgeries or interventional procedures. Sometimes, if for certain types of pain, you can go in and actually target the nerves that where we think the pain's coming from, and actually zap those nerves to try to resolve the pain. So there's lots of different procedures, medications, and things. That's not the limit of what I know, but that's the kind of the chiefly the area that we as physicians will manage. Nursing supports in terms of like more practical care, things like how do we manage the very specific details of day-to-day management of a human being who has palliative needs, things like dressing changes, and managing wounds, getting in and out of bed safely, for example, ambulating. There are really a lot of key things that nurses are experts in that I will know about, but I'm not the expert that they are in those areas. We have pharmacists that are more expert in certain types of medication options. We have social workers who are really expert in, they're very good at counseling, they're very good at planning, but they also know the support system in and out. So how to get a bereavement benefits or sick benefits. If you have a critically ill loved one, how do you activate your insurance? How do you get all the resources that are accessible to you? If there are family crises and you need to sort of help mediate some more challenging crises, there's lots of issues that come up that a physician can manage and sometimes can manage quite well, but that could be perhaps better managed by somebody else with those specialized skill sets. And so, it's definitely a team sport, and we work really well that way. Now, and that's the thing. Those are just the people who maybe call themselves a palliative care social worker or a palliative care pharmacist. But of course, social workers of all stripes would have certainly the basic skills in those areas and be quite knowledgeable in those areas. Ditto the nurses, ditto the pharmacists, and ideally the physicians should have some basic levels as well. So it's not a person, it's not a place either. So again, you can get palliative care at home. You can get palliative care in an acute care hospital with consulting teams. You can get palliative care sometimes from your primary care provider without any additional person getting involved. That really what you're doing is you're just making you're sort of integrating the palliative care principles into what you're already doing, right? So a cardiologist will start you on some comfort medications and maybe change around some of the pills that you're on, with the understanding that we're now prioritizing comfort and minimizing, for example, extra blood tests and trips to the doctor in the interest of trying to promote your quality of life. And that's all done by the same person without changing your team at all. So it's more about integrating or adopting what we say is a palliative approach to care, right? That might be the best way to put it.
And you raised something that I know I'm sure our participants will be interested in. You talked about, at the hospital, home. We hear a lot about hospice care and we hear about palliative care and we hear that, the majority of Canadians want to die at home. We hear about palliative care units. So can you just sort of describe what that
So
is?
So again, I would say that the situation around this is complicated but simple. There's palliative care can and ideally should be provided in almost any setting, any location. And ideally, we always try to respect the wishes of a patient and family as best we can when it comes to finding the place that one might receive their end of life care. It is definitely true that people are less interested in dying in an acute care hospital in an acute care bed. They are generally more interested in dying at home or in a non-hospital setting. There are practical limitations to that, though. And so I just want to be very clear that sometimes in the rush to do all of this and in the rush to promote palliative care and cite the advantages of palliative care, we don't want to create unrealistic expectations because everyone is different. So I would say that a lot of the considerations about where you might get palliative care down the road will depend heavily on what medical condition you end up having and what is the cause of your suffering. A lot is going to depend on geographically where you are. A lot is going to depend on your own social structure around you. So while the home care system and the palliative home care system can be very robust in many parts of the country, we in Ottawa, for example, we are absolutely spoiled for the number of home visiting physicians that do only palliative care, as well as home visiting family doctors that will provide palliative care. We also have something called the Regional Palliative Consultation Team, which is run out of Briere, where I currently am sitting. And that is a really awesome team that supports all of the Champlain-Lynn, or the Champlain region, I should say. And you have specialized nurses that will go and support general practitioners who do home care to help them deliver the optimal palliative care to people at home. And so we have a wealth of different options, including, of course, outpatient clinics that coordinate with home care as well. So there's many ways in which you can potentially get palliative care in your home. That doesn't mean that everybody can get palliative care in their home. That doesn't mean that it will work for everybody and be appropriate, because often the needs go beyond the purely medical to the more supportive, right? So, and again, if you happen to be somebody who is fairly high functioning and independent or somebody who has a really good informal network of caregivers, for example, family members who are unpaid, then adding some hours of palliative personal support worker and nursing and home visiting doctors. And we can put equipment in the home, and that's going to probably work pretty well. For most cases, we could probably keep you at home for a very long time, possibly until the very end. If you are somebody who has much more complicated needs, where, somebody who's at risk of sudden events, bleeding, seizures, that type of thing, which are rare, I just want to reassure everybody, they're not common. Or if you're somebody who has a bit more of a limited social structure around you, like you have a very limited network of informal caregivers, then that's going to be a bit harder. So one of the things, of course, that increasingly is happening is we see we've been so successful at managing things like heart disease and now even cancer. People are living much longer than they used to, but we get frailty with that, right? So we get as we get to be higher mileage cars, if I can put it that way, the higher mileage cars need a little more care, and they can't often do the things that they used to do for themselves. And then if you're a caregiver, for example, if you live with a spouse, that could work well unless your spouse is also of a similar age to you and also has medical conditions that makes them frail. So, very commonly the classic scenario of a sort of an older gentleman with chronic conditions that are generally getting worse, who is needing help with more and more things, and then is relying increasingly on maybe a frailer spouse who is themselves in need of support. That's not going to work very well, and that's a potentially risky situation health-wise for both of them. So I think in some situations you have to acknowledge that no amount of personal support worker hours or nursing is going to make that a safe situation. There are times when you are going to be left to fend for yourself, and if you can't do that reliably, then that's dangerous, and it's not a good idea to try to set people up for that, because not only will the patient themselves suffer, the caregiver might suffer too. So the last thing you want to do is try to make things good for one person and end up making things bad for two people. And so we have to be honest about that. There are certain types of complicated medical situations with very advanced symptoms that also might not be appropriate to be managed in the home, even with really good medical care and medical follow-up. I sometimes look at people and I'd say, look, guys, I really don't think this is a good idea to try to manage this at home, because we can do a lot in the home, but it's not the same thing as having a nurse who's right there all the time, like you do in a facility or a hospice or a palliative care unit, a doctor that's always on call. There are certain situations, not extremely common situations, but certain situations where I don't think it's a good idea, with any amount of family willing to pitch in, to try to do this outside of a healthcare facility. As a general rule, though, we can often or almost always get people out of an acute care hospital. And so that I think that's the good part is that we will try to get you to a place like the palliative care unit here at Bruyere, or like the hospices that are managed by Hospice Care Ottawa, or some of the more rural hospices where it's an inpatient facility, 24 hours a day nursing, support workers, but you get your own room and it's quiet. You don't have like people jetting down the hall all the time with the floor cleaner. You don't have the bell going off all the time and the fire alarm going off every 20 minutes. It's a peaceful environment, and it can often look like a home type environment too. And
Yeah, so
that's what many people want.
so that raises, because you've talked about hospice, and I mean, maybe you can talk a little bit more about that. I understand that hospice provides like a residence for people, um, a bed, a place to be. I also understand that hospice provides other things in the community, like
Yes.
day hospice, visitors, that kind of
Yes.
thing. And who would benefit from hospice?
Well,
That's maybe that's too general.
possibly anyone and everyone, and that's the thing. So generally speaking, hospices, and there's been a massive expansion in hospice beds over the past several years in this province, particularly the past 8, 9 years. Number of hospice beds in Ottawa have doubled. In Ontario have doubled, which is amazing. And the funding has gone up for those beds as well, because it used to be a bit of a tight funding where hospices had to fundraise a large amount of their operating expenses, and that's all been changed. So that's great. So hospices, though, typically inpatient facilities, and there are many of them that are maybe smaller facilities, like 8 to 12 beds, but they would be located more in communities. They look more like home type environments, but they are staff like facilities with nurses and support workers, like I said. But some of these hospices also run day programs where somebody can come in, and if they need to be watched and kept an eye on during the day, if a caregiver needs a break or if a caregiver is working, they will run a system like that where they can support people that way. That can be helpful. There are some that are purely community hospices, so they'll deliver services to people in their homes, whether that's supportive care, equipment, spiritual care. There's lots of different types of support that could be delivered in the home type environment. So some of these hospices essentially are community hubs for those types of services, and many of them offer bereavement supports as well to family members. Even if if you were a patient, but they can be a good connection point, even for people who are not necessarily patients there, that they can connect you with resources or sometimes provide those resources themselves. So every hospice is a little different, but those are the types of services that they will provide. For inpatient services, they tend to be more limited in terms of duration. So that's usually for people who are in their final days and weeks. They're not supposed to have people stay for months and years, kind of thing. And I think one of your attendees has made a comment that now increasingly we're trying to deliver that type of support for individuals who may be in like chronic care or long-term care. So long-term care, there's a very large population of long-term care residents in Ontario. It has historically been an area where palliative care principles were not always as integrated as they might have been. We have made a real push to improve palliative care and long-term care. It's been an area of focus. And I would say that certainly, like I told you about the regional palliative consultation team, those teams are going into long-term care homes now to really try to make sure that patients are supported. Because if you already have you're already settled in the place. Often these feel like homes to these individuals. They may have been there a long time. The idea of snatching those people out at the last minute and sending them to another facility or even an emergency room for their end of life care, it feels wrong. And we'd love to be able to put a stop to that as much as possible, to try to focus on providing care on site for these individuals. And we're increasingly able to do that as well. So that would be another important community resource.
Great. And so that raises another question for me. If I were diagnosed with a serious illness, a serious chronic illness, and I wanted to access palliative care, like how would I do that? Can I call up myself? Can do it? Does
So
my physician or nurse have
generally
to do it?
speaking, yeah, I mean, you can always call, you can always ask, but the best way to access supports is through one of your care providers
Okay.
existing. So because depending on where you are, what you're doing, there, a Google search can sometimes not give you the kind of answer that you're looking for, or you'll be referred to the wrong program. Even as good as AI has become, it's not that good. So I would say the best thing to do is if you feel like you're somebody for whom a palliative approach might be becoming appropriate, either because of medical conditions that you have or a combination of medical conditions, prognosis and symptoms, that this is something that you really want to make sure is addressed, and you're not sure it's being addressed as well as it could be, to talk first of all to your primary care provider. If you have a family doctor, that's the person to talk to. If you have if you have like one particular chronic condition or a cancer, for example, so you have a specialist who does a lot of your core care, like a cardiologist or an oncologist, raise it with them. They're often physicians will often be. It's sort of like the junior high dance, if you remember what those, where everybody's like, everybody's on one side and the other side of the room, and everybody wants to dance, but nobody wants to make the first move. And so people are sometimes hesitant to make that initial approach. I think if you make the approach and sort of raise it with your physician, the physician will often feel a lot more comfortable talking about it with you and might be afraid of your reaction. If they may have been already thinking, geez, I really need to bring this up, but I don't want to upset them because I've had them as a patient for a long time. You'd be surprised. Often it's a door waiting to be pushed. And again, if you feel like you're not getting the response you want, try to continue to work at that. There are resources that you can go to. So there's a Champlain Hospice Palliative Care website as well that's filled with great resources. And that would probably be the place I would direct you to for your first port of call. If you're looking to just find out a bit more about services available and options. Keep bearing in mind that it's can be a long list of resources, and not all of those resources may be available to you depending on your situation. So, but that would be another good place to start. So start with
Great.
your own care providers and or the website.
Great. Thank you. At the beginning, you talked about all the work that you've done over the years, helping clinicians have conversations with people. And at Compassionate Ottawa, we run workshops in the community that are called Conversations in Advanced Care Planning. And the goal of the workshop is to get people to start talking about values, wishes, and beliefs. So we're not talking about the goals of care and treatment plan kind of thing you've talked about.
Right.
We're talking about quality of life. What makes me want to get up every day? What brings quality to my life? And they're very interactive workshops where we get people to talk about their values, talk about their wishes. Now,
If I can
have
echo
you,
that, just to your
yeah,
audience there to endorse this, because like I'm going to tell you that I'm going to, there are things that I can talk to you about anything you want. There are things that I have maybe more expertise in around medications, other non-medical things, types of counseling. I can tell you about experiences that I've had. What I can't really tell you to do is how to run your life and what you should be focusing on. That can only come from you. And so what I think a lot of people struggle with is that you sort of gotten into a pattern of one foot in front of the other, one foot in front of the other. And then it's sort of like you're confronted by a serious illness in a situation where all of a sudden you have a limited amount of time. And then there's all this rushing into your head and you're trying to sort of make sense of it all. Then it can be very hard to sort of have this set of priorities and then decide, okay, now what am I going to focus on? What's going to be my principal thing? It's very, very helpful if you have, already thought about things like this and already sort of, start to put some pieces on the board. It doesn't have to be specifics, just thinking in terms of what is valuable to you. What do you consider quality of life? What would you like to be doing, right? What are things that are enjoyable to you? And here's the secret. Don't tell anyone. Start doing those things now, right? Don't wait until you meet someone like me who says, you really should have some, try to enjoy and amp up the quality of your life. Because if you've waited until I tell you to do that, you've waited too long. And I just want to say that it's not the work of this guy that's going to make that better. It's the work of people working in Compassionate Ottawa, trying to help everybody fill out that part of the quality of life. And I really just want to underscore that message. I'm sorry, I interrupted you.
Yeah, no, that's fine. That was going to be my question, actually. Do you see value in that in terms of your work when people come who've already done some of that pre-work?
I love, like, again, I get paid the same no matter what happens. So let's be clear. I'm joking. I don't, obviously we all need a salary, but the reality is that it is, I'll take anybody regardless of how prepared they are, of course, as part of my job is to help people prepare. But I can tell you who's going to get the most out of an interaction with me. And in many cases, by the time you've seen me, everything is obvious, and you've sort of already come to that point in your life. And my interaction is more a counseling one, a supportive one. I can help put some specifics on the table for you, but again, I'm always going to be able to do that much more effectively if the values side of it are clear and the priorities side of it are clear, because that's not in the textbook for me, right? So that's where I have to, only you can write that chapter in your own book. And so people who have gone through that process, it's a much easier conversation with me, and certainly a much more fulfilling process, I think, for the individual who's going through it.
Okay. So we're getting close to when we want to open it up to questions, but I wanted to, you've been involved in research, I think your whole career as it's gone on. And so I'd like you to share with us sort of what you see some of the based on your experience in your research, the future, like what
Yes,
are we
I
headed
was
for?
trying not to geek out too much on this because I know that what the focus of Compassionate Ottawa is, and most of
Yeah.
the questions are. Dr. Downer, could you tell us about some of the statistical models that you use? Um, Never been asked once of me. Strangely, I don't. I wish. I feel like there's a pattern there, but no. I think the thing for me that I think is most interesting is I have become hyper focused on better understanding and identifying more effective treatments for a host of symptoms that we have. What's clear is that palliative care is effective. There's no question that palliative care can help people, but I have to say that there are limitations in what we can do. We are largely using the same treatments we've used for the past 40 years. We're probably the field of medicine that has changed the least in that time. Much of the work that's been done has been simply on accepting the existence of palliative care and on demonstrating the value of integrating palliative care at an earlier phase in people's illness. That's been the bulk of the research. But now, as we're seeing these incredible breakthroughs in heart disease. Adjusted mortality from heart disease has fallen by 2/3 in the past 40, 50 years. And we're seeing some incredible breakthroughs in cancer therapy, like new treatments that have made, cancers that used to be a death sentence are now almost a chronic illness. And that is, as somebody who's managed these people over the years, it gives me tingles just to think about what might lie down the road. Now there are hundreds of cancers. We're talking about a small number of cancers, right? So don't everybody assume that if you get a cancer that it's curable. I don't want anyone to assume that. But I think when you see things like that happening in other fields, you have to think, what is possible for us in palliative care? Because we still see many people who do have pain despite our best efforts, physical symptoms despite our best efforts. But the thing that's most concerning to me now has become existential and psychological distress. The legalization and availability of MAID has brought that to the fore, because far and away the number 1, 2, and 3 reasons why people get MAID is because of existential distress. So this is essentially a serious form of distress brought on by the fact that an advanced illness has essentially robbed you of the ability to do things that gave your life meaning, activities that gave you a sense of community with others, and the role that you might have played in the lives of others, to the point that many people feel like they've just, they're approaching the end. They've feeling some distress by that, and it's really, we have very little in the way of effective treatments to offer for those. What we really need are very effective, scalable, and rapidly effective treatments. So one of the areas of research I'm working on is newer, novel, and scalable treatments for existential distress. We've just published a study this year using microdose psilocybin. So those of you familiar with psychedelic medications, there's been a lot of buzz, no pun intended, on psychedelic medications in the media and using large doses that are hallucinogenic. But it turns out that using very small doses repeatedly may be just as effective, and we're starting to do some studies to look at that, and we've had some very exciting results. And this could be a real game changer for us. We're using also something known as RTMS, or transcranial magnetic stimulation, which is being used increasingly by psychiatrists to treat depression, anxiety, and it can also work very quickly with sort of a low side effect profile, and makes it potentially another scalable and if it's shown to be effective. Again, early studies, don't get ahead of ourselves here, but if it does prove to be effective, and it could be very scalable, this is the kind of option that we can bring. Now, when you realize that up to 40% of people who are in approaching the final period of their life, 40% are reporting severe existential distress. That's our target, right? Like, this is the most prevalent, the most burdensome symptom that people report, more than pain, more than any physical symptom. And so we've got a program of research that's heavily focused on that. And the other thing, I was very fortunate, a year ago, there was a big competition for a $6 million grant from the Canadian Cancer Society and Brain Canada and we were fortunate to win. We were very lucky. We won that, and we're using that money to build a national infrastructure. So a number of maybe up to a dozen hubs, so large centers across Canada, they're going to collaborate very closely together to conduct the same studies. So it's very hard sometimes as a single center to do big clinical studies to test new treatments, because you can't get enough patients, at a single center to conduct this study. But if you have a dozen centers working together, collaborating, all doing the same study, and you have infrastructure built, not only can you do much bigger studies, but you can do them at much lower cost and in much more rapidly. So we can start to answer some of the complicated clinical questions. We can start to identify new therapies and test them rapidly for integration into care. So really the idea of what, practice-informed research, but then research-informed practice. So when we identify something good, we use this network to disseminate it really quickly. And we're hoping that in the coming years that this will be an effective machine, effectively to start to trial a lot of do a lot of these trials and research that will help us make the kind of big breakthroughs that you're seeing in these other fields. And that's what we're sort of fixated on at the moment. So, and that's being led right here in Ottawa, by the way, right here in Briere. So very, you should be proud of your city. We're very proud to be that, but it is a team effort. It's not national. We're not here to hog the glory. It's like I said, it's a team sport, and that's what we're super excited about. And our hope is that we can, test a range of different, treatments for pain, treatments for fatigue, treatments for psychological distress, all sorts of different treatments. We're even going to do a study of mentorship of caregivers, so helping connect caregivers with other caregivers to help them feel better supported in their roles. So again, we're trying to use this to answer some of the big burning questions in our field and the big sort of gaps in our knowledge.
Right. Thank you for that. This is obviously a massive conversation that could go on for some time. I'd like to make a couple of comments, and then I'd like to open it up for questions and comments. First of all, James, you mentioned about the Champlain Hospice Palliative Care Program. We, as part of what people will be sent following this webinar, we have links to the resource list that you talked about, so people can get access to that information if they've got more questions and they want to look further. James, you also raised the issue of the well, I mean, I was shocked when you said 40% of people have existential suffering. It's your biggest challenge. And it's the 1, 2, and 3 reason I think you said for MAID. So James has graciously agreed to be a leader, to engage in another conversation with leaders about MAID in the fall. So, we'll go further with that conversation then. So, Paula, I wonder if you would join us and if there's questions or comments that James can address.
Yes, definitely. Just on the tail end of what you just said, Louise, recognizing that we will have a deeper dive into MAID in the fall, there are a few questions specifically about it. And so just as a more of a brief one, just to make sure we don't leave that hanging, I was wondering, James, if we could ask you if you could briefly describe how MAID relates to palliative care.
So again, MAID is not part of palliative care by definition, right? So we have a definition of palliative care that it doesn't seek to prolong or shorten life. And it's important to make that distinction because MAID continues to be a controversial issue in some areas, and palliative care providers historically, for reasons that I won't get into, many palliative care providers have been very opposed to MAID. And what we don't want to do is create a situation where there's an obligation, the two are lumped together. That should not be happening. Palliative MAID is a service. It is obviously a medical treatment to which Canadians have the right now, and there are. It often comes up in the context of somebody who is also receiving palliative care. So somewhere between 75–80% of MAID recipients are already getting palliative care when they're making the request for MAID. So the two come up together. They're often raised in the same context because it is about people giving a relative prioritization of quality of life over quantity of life. And without getting into the moral distinctions between MAID and palliative care, I will just point out that that's often why I think people think of them together. But they are, strictly speaking, MAID is not part of palliative care. But many people who receive palliative care also go on to ask about MAID, and many people who are going to receive MAID should pretty much invariably be offered palliative care if they aren't already receiving it and have access to it. That's very important. Some palliative care providers will do MAID. Some palliative care providers do not do MAID and are opposed to it. You can get MAID in some palliative care facilities. You cannot get MAID in some palliative care facilities. So those are for sometimes religious or moral reasons, and sometimes for institutional policy reasons. So it's a bit of a sticky wicket. To get into that would be a bit complicated. I just want to say that if MAID is something you are considering or thinking about, it's good to talk about that early on, just so that you can avoid frustrations or challenges related to some of the logistics associated with it. In Champlain, there is a Champlain MAID team. There's a coordinator. They coordinate this. So generally speaking, access in the Champlain area should be pretty good if you want to get it. But there's this distinct pathway for getting that.
Great, thank you.
And then the next question asks, how are palliative care services culturally sensitive?
It's a great question. I would say in many ways we are, and in some ways we could do better. And I think historically, when you look at so palliative care was a field that grew out of cancer care. And part of the reason that, and even today, about 60–70% of all palliative care encounters are with somebody who has cancer. When you consider that only about 25% of the population has cancer and dies of cancer, that still shows a real cancer bias. And a lot of our models around this is that it depends on, people who are usually in the final weeks or months of life. That corresponds to a time when generally people with cancer are having a lot of changes in their care. And it's not applicable to non-cancer illness. So that's one big bias that you see. The other thing is that it's often the heavy emphasis in palliative care and palliative care interactions is on what we call patient-centeredness, patient-centered care, which is often interpreted as a heavy emphasis on autonomy. It doesn't have to mean that. Patient-centered care ideally is patient values-centered care. So if patients themselves aren't opting for a pure, individual autonomy approach, then it's not patient-centered to force them to make decisions that they don't want to make or aren't prepared to make. And in many cases, our sort of model is autonomy focused, and sometimes we struggle in situations where individuals might not want very fulsome disclosures of their medical situation and their options. and they want to defer to family members. The family members may be very resistant to certain types of things and openly discussing this. Some people are very opposed to speaking openly about prognosis and what might lie in the future for somebody who's got a terminal illness, because they feel like it might be a negative, thinking negatively or negative thoughts. And these can be, in palliative care, we can navigate that, and we have experience navigating that. But I'm always clear to tell people, like, my preference is to be more open in general in communication and to involve people in decisions, simply because trying to not do that can lead to unintended consequences. So things get disclosed. There are always misunderstandings with everyone. Regardless of what you're trying to do, someone will misunderstand something. And so the more you can be open and direct, the less likely you are to bump into that particular problem. But from a standpoint of cultural sensitivity, we do need to be open-minded and accept that not everybody fully embraces that. And there are still times when I see people where we don't use the word palliative, and we don't talk about death and dying, but they're perfectly happy with that. So, for example, maybe I could just give you a quick example of how I might approach a situation with somebody where a family is very resistant to me talking about anything to do with death and dying, telling them what's going on, et cetera, et cetera. Then I'll often sort of say, okay, I will talk to the family. First of all, I always have to get permission from the patient to talk to the family without them present. So I do that. They almost invariably say yes. But then I'll sort of say to the family, and I'll tell them how I'm going to do it to get them on side, because I don't want to alienate the family. Families often sort of say, no, we make the decisions, tell us the information. I can do that, but I can only do that if the patient is okay with that, right? Which deviates somewhat from legal practices in other parts of the world. And so you just have to kind of say, look, and there's a reason, like, don't hate me, don't be angry at me. This is the law. I have to follow the law. Let's work together. Here's how I'm going to say this, is that I usually say, hi, I'm Dr. Downer. I was hoping to have a conversation just about what's going on and where we're going to go from here. Generally in my practice, I kind of have two kinds of people. I have some people who, they want to be the person to make all the decisions. They want to hear the information about their situation. They want to know all the options. They want to know what's going to happen to them in the future, and they want to be the one to make their decisions. I also have some people who are not like that. They prefer, they want to know the basics. They just want to know what they need to know. But when it comes to information about what's their illness, what's the future going to look like for them, that sort of thing, they don't really want to know all that information. They'd rather that I speak to their family about some of those things that, may be a more difficult subject. And I'm happy to go either way. Are you more like this person, or are you more like that person? And in doing that, I sort of try to make it as neutral as possible, that I'm not telling you that you really want to be like this. You don't want to be like, you want to try to make it clear that both are valid options, and that there are other people, if they don't want to be involved in those decisions and want to know information, there are other people like them too, and that's okay, because you don't want to make them feel pressured into stuff that they're not ready for. And so I say, sometimes I'll say, well, I don't know. Well, I prefer if we do it this way, because sometimes it can avoid miscommunications. But sometimes people find talking about their health and talking about the future, they can find that upsetting. And they find out that it can be quite upsetting. And the last thing I want to do is make you upset if I don't have to. So, just tell me, I'm comfortable with anything, but just tell me what would make you feel the most comfortable. And then again, sometimes I will say, talk to the family. And I'm like, great, we're good. And then I've managed to navigate that. Nobody's upset with me. Or if the patient says, I want to know, what are you talking about? Well, my son, don't listen to him. And you sort of say, okay. And then what is, the son has to come to terms with that, right? At the end of the day, it's black and white. I don't have the option to deny information. So that's one way we do it. But there are often, even within that parameter, you have community based decision making, or sort of group family based decision making. And in general, I would say, regardless of the approach we take to any situation, I always think we should try to aim for consensus as much as possible. I mean, there's sometimes, the patient is in charge. Or if the patient's not able to make decisions, there is a rank order of substitute decision makers. And it's never hard to find out who's at the top of that list, or it's rarely hard. But people fixate way too much on who that person is, rather than why don't we just get everyone in the room and let's talk about what's going on? Because if we all agree on what the right answer is, we don't have to get into the potentially upsetting question of who's really in charge here. And in many cases, also to make it more simple, we tie ourselves in knots about decisions that aren't actually decisions. Where there's a very obvious best course of action based on the medical situation or the patient's stated values, and that we're tying ourselves in knots about feeling that we're going to take on the responsibility of a big decision when there's actually no decision to be made at all. And just it's simply a matter of recognizing the situation that we're in rather than us making that decision. So I'm sorry, that's a long-winded answer. I'm trying to do justice to the cultural sensitivity question, but to give you a practical idea about how we might address culturally sensitive issues. Many hospices and palliative care units will also do culturally specific end-of-life practices. Smudging, for example, you have to do a modified version of it in many hospitals because of the oxygen. You can't have open flame going around, so they do sometimes a liquid smudge, for example, for First Nations cultures. But we can do lots of other things around sort of end-of-life practices for people who are of Buddhist or Hindu faith, where where there are specific things that you need to avoid at or near the end of life. For people who have to get very quickly to a funeral because they can't do anything to preservation of the body, you have to bury them before the next sunset, et cetera, et cetera. So there are many ways in which we try to be culturally sensitive around decision making and around end of life practices. I hope that's helpful.
Thank you.
And then the next question asks, how do or can palliative care and dementia care work together to support a family with a member who has Alzheimer's?
Yes, excellent question, and I wish you didn't ask it because now I have to answer it. That's a tough one, and I'll tell you, it's the reason that palliative care remains heavily rooted in cancer care is because it's much more straightforward in many ways. That you're dealing with fairly straightforward, heavy focus on physical symptoms for somebody who's got a relatively short period of time, and often who is able to participate in their own decision making. As we get away from that paradigm, so you end up getting into non-cancer illnesses are chronic. They're unpredictable in terms of their time course, but many of them, it's very, very long, and it's hard to predict when an event might happen for that individual. So the same two people who look very similar, one could be in the final 3 months of their life, and another could have another 5-10 years to live. So care planning can be very challenging. When do you think about, sometimes the emphasis has been on when do we send them to the hospice, palliative care, when do we send them to the palliative care units, when do we send them to the hospices? And that's a real challenge because, again, it can be very challenging to predict when that person is in that final period of life, and you go and then you have to send them back, and then you have to. So that's why more the emphasis is on trying to integrate palliative care in situ for these individuals without having to get into the sticky question of how close they are to the end. So making sure that, meticulous attention to symptoms remains the issue. They tend to have different symptoms related to their Alzheimer's disease than somebody with cancer, for example, where it's more physical symptoms or existential distress. People with Alzheimer's disease, particularly as it becomes more advanced, they're not necessarily feeling the same kind of existential distress, but they may be feeling mood symptoms like depression or sometimes anxiety. And very commonly they will have moments of agitation or delirium where they may be called behavioral symptoms or reactive symptoms, where they will suddenly start to, become distressed by the people around them and what they're doing. Regular aspects of care will be felt by them as assault. And so they will fight for their lives, and they'll hit people. And this is where often a context of where healthcare workers can be assaulted and family members can be assaulted. And yes, they are bedbound, and yes, they look frail, but boy, they can pack a wallop. I've taken a few punches in my day when I wasn't quick enough to get out of the way. And, so when you're trying to address people's needs with Alzheimer's, they can be complicated in different ways, right? So you're trying to help families plan. You're trying to help them do it with a patient who may not be able to participate in their own care. So there's the distress of having to make care on the behalf. They have supportive needs and maybe feelings of guilt. If there's somebody who's, I always want to stay at home, I never want to go anywhere. But you get to a point where you just can't honor that wish anymore safely. So having to get that person into long-term care or even just a retirement home, and they can be very resistant to that. And that can be very distressing for people. The physical symptoms are sometimes present if they have, they've broken a bone or something in the course of what's happened to them. But often it's less about the physical symptoms and more about trying to help with their mood, help control those moments of agitation without depressing them, without completely suppressing their mobility and their interactivity, right? And that's a delicate balance that you have to strike. It's not always easy. It's not always straightforward. We are working very hard on it. And it's important to acknowledge that it's not just a matter of taking what we do in cancer care and pasting it onto this other patient population, because that's just not that's not right. I hope that was helpful. Sorry, that was my brief version.
Great.
And the next question we have is, can you explain more what existential distress is and how that presents?
I can. To be clear, existential distress is not, people write PhDs on what this is, and I don't think it has a universal definition that everybody would recognize and accept. The definition that I use is sort of what I alluded to before. It's something like a loss of purpose. So what we define ourselves as humans. Humans are what we call relational beings. So much of how we define ourselves, our purpose, and our role in the world is in terms of our actions, our activities, and the role that we play in the lives of others, right? So if you read a bio on social media, father, dog father, husband, wife, mother, teacher, doctor, you'll write things like your role and your sort of network around you and what you do, and then your activities. So I'm like competitive swimmer, soccer player, I do crochet, like whatever, all sorts of things that are your activities, and these are the fun things you do, right? And for many people, their social group derives from those activities, and it can be anything from sports to book club to cooking classes to curling to crochet to whatever. So that's what often forms our sense of identity and our sense of purpose. And people love doing this, right? Like I got 4 kids. I kind of involved in hockey, and I'm like, you can see people who are like clearly have been coming to the same rink for decades as a volunteer just because they love it, right? So then an illness comes along and takes that away from you. So you can't play the role that you played in the lives of others for many, many years. You can't do the activity that you've always done. And it's not just that you enjoy doing it, but that was your social outlet. That was your link into this group of humans that had the same shared interests around which you formed, you formed this group of who have a shared interest. So when the illness takes away your ability to do that, it's not just an illness, right? It actually is an assault on your identity, on your person, on your sense of who you are. And that's why it can be very challenging to overcome this, right? So you're in a situation now where you suddenly have to adjust. You have to find a new sense of purpose or a new way to sustain yourself, having lost all of that. What's interesting is that it's not simply a sense of not being able to do things. It's not a sense of just being dependent on others for things. And this is a really important distinction. So when you look at the rates of MAID with different conditions, cancer and ALS have by far the highest rates of MAID, and far lower are things like heart disease and frailty and Alzheimer's disease. So just it's not the question that you can't do something, it's often the speed with which you lost the ability to do things. So it's clear that people can adjust, and over time you can adjust your expectations and form new interests and form a new sense of purpose if the changes are slow. But when the changes are quick, it seems to be much harder for people to do that. And again, this is not simply a question of being lonely, right? So this is not a question of taking somebody who's done a certain set of activities and had a certain social group their whole life, and now all of a sudden you're getting a teenage volunteer to come play cards with you once a week or play the piano. That's not replacing what they lost, right? It's not simply just putting another human with them. It's that sense of community around shared interests and or the role that you played in the life of others that you really enjoyed playing and that gave you purpose. And it's that loss of ability to do that creates that sense of distress that can be very difficult to overcome. I hope that's about the shortest version of that answer I can give. So I hope that's helpful.
Very, yeah, thank you.
Very helpful, I think. And the last question we have, and it's a good one to end on, I think, because it kind of wraps up everything with a nice little bow, is James, what changes would you most like to see in how Canadians understand and access palliative care?
Mm.
Well, I think that's a great question, and I mean, thinking about it a little bit, I would say that like let's not sell ourselves short. We're, the talk of crises. I think everyone has gotten into the thing where everything's a crisis and everything's the worst it's ever been, and nothing's ever been as bad as it's been, etc. And I would have to say that don't believe the hype. I actually think that by a variety of metrics, things are going well and really well for a lot of aspects of healthcare, even while we are struggling in others, which I think are well known. When it comes to palliative care, the last 10 years has been an unprecedented, an absolute, indisputable golden age for palliative care in this country. There's no question. The number of palliative care providers has ballooned, has expanded, has increased exponentially. The number of palliative care beds has increased. The interest in palliative care, the acceptance of palliative care, and the use of palliative care. So, the last 10 years has seen a growth in the utilization of palliative care at a rate that we've never seen in Canadian history. Never. So my division here in Ottawa, for example, I took over the lead job in 2018. We were 21 physicians. We're now 50.
Wow.
Just in my division, and that doesn't count the community groups that have also been expanding and other surrounding communities that have added physicians. And this, you're seeing a similar pattern across the province and in most of the country. Not all of it, but most of it. So people are shoveling money at palliative care, and it is showing up in what we do. The demand for palliative care, I think I'd say the only problem is that the demand for palliative care has probably grown a little faster than the incredible growth in the supply, which maybe gives us the ongoing sensation of a system under stress. So to a certain degree, we're victims of our own propaganda in the sense that we're going around promoting an awareness and acceptance of palliative care. And we've been really successful at it to the point that now everyone is really focused on and demanding better quality palliative and end-of-life care. And we have had a dramatic expansion in our resources and our ability to address that. And I would say we've almost kept up, not quite, but we need a little bit more resources, but there's only so fast you can expand. So I would say the key thing is keep doing what you're doing. The other thing that we can do, what I would like to see is it's more of a ensuring that basic aspects of social supports and community supports are maintained. So among the financial crises of the past several years and the inflation crisis, bumping up resources around supporting people who may be experiencing social distress, right? So can we address some of the upstream causes of why people get chronic illness and why chronic illness progresses? And we're actually seeing a lot of that. We're seeing things like the federal disability benefit come in, national pharmacare, national dental care. None of these programs are perfect. I'm not saying they're perfect. I'm not here to advertise for any government or anything else like that. Because I'll say, just to be clear, the feds have done a great job in the past 10 years. The provincial government has done a fantastic job as well in many of these areas around palliative care funding in the last 10 years. So I'm trying to be maybe not nonpartisan, but at least bipartisan. And a lot of people are doing a lot of good things. We need to keep going, though, on some of the social supports and some of the community supports. I think a better organization and integration across the system would be helpful because there are still a lot of silos. Ottawa, I'd say, is very well integrated as a rule, but there's still challenges when people go from hospital to home. So we've just come out with a provincial model of care for improving palliative care in the hospital environment. And there's sort of three emphases of that model. One of them is on timely identification. So we're trying to build better models. And I talked to you a bit about the automated systems that we're using. We're trying to build those out so that we're getting upstream and identifying individuals with unmet needs a little earlier than we currently are. We're trying to build capacity within the system, so make sure that every person who does healthcare has at least a fundamental basic skill set around palliative care provision, can meet some of those needs without constantly having to send everybody to a specialist. And then number three, transitions, and in building up that informational infrastructure to help smooth those transitions, because people in palliative settings are often changing context, home to hospital, hospital to hospice, palliative care units to home. Lots of movement in the system, and having a single platform for communicating among healthcare providers would be a tremendous boon to us. And making sure that, for example, home care services are well coordinated, well led, and well integrated into the care that is provided to everybody. So I'd say on a high level, if I had to ask for something, it's you guys keep doing what you're doing because you're doing a great job. This is the best we've ever done at this, so keep it up. But then those changes that need to happen at a system level to make it just a little bit better.
Great. Thank you.
So that wraps up our Q&A period. Thank you to everyone who submitted your questions, and thank you so much for your answers to those questions. Louise, I'll pass it back to you for some final remarks.
Sure. So first of all, James, I'd like to thank you for spending this morning with us. This has been very informative and really it's such a massive topic, and you've done such a great job of giving us the essence and providing us, I think, with hope for the future too, if I might say. And congratulations on all the wonderful clinical and research work that you're doing. It's very, very impressive.
Thank you very much, Louise. It's always a pleasure. And just on a personal level, for those in the audience who don't know, Louise dedicated a great chunk of her life towards promoting advanced care planning, and helping to socialize these topics in society. So when I was knee high to a grasshopper and just entering the scene, Louise was well established and one of the people that I think all of us have to thank that the successes of the past 10 years were laid on foundations or were built on foundations laid by people like you who worked, I think, thanklessly, frankly, for many, many, many years before we started to see these amazing successes. So
Thank
right
you
back
for
at
that.
you.
Well, thank you. I appreciate that. And thanks to all our participants for joining us. We're recording the webinar. It'll be on our website very soon, and we'll send it to you. And please share it with others that you think might benefit from this. We're also going to send you a very brief 3-minute survey so we can learn about your experience, evaluate what we're doing so we can keep getting better. And I just like to say that Compassionate Ottawa is a registered charity, and donations help us to continue to provide our free community education programs that help people, as I described, build the knowledge and confidence and connections that they need to navigate serious illness, to navigate grief and loss, and to engage in advanced care planning. So if you do want to support our work, you can make a donation through Canada Helps on our website, and we'll include that link to the follow-up email when we get back to you. So again, thank you for being part of our conversation. We'll be back in touch with our next conversation, which will happen in the fall, and we'll see you then.